So I have nothing to disclose. I may use the word hormonal therapy. I'm not sure if that's an off-label use. I have selected 4 issues which I think are currently unstable in the classification of endometrial carcinoma, and will discuss how I anticipate that will be changed in near future. So there's nothing fancy for years coming down the road, but will change probably relatively soon. So the first issue, which causes quite a lot of eye rolling in some of our tumor board rounds, is that if there's an endometrial biopsy and the biopsy is grade 1 and the hysterectomy is grade 3. I just want to explain why this happens. Can you put the slides maybe on this screen as well? Is that possible? Just to remind you, the definition of grade by FIGO and WH1 is basically for endometrioid carcinoma just based on the solid architecture. And there are 2 thresholds. It's more than 6% and more than 50%. And the solid architecture should be not glandular and non-squamous. There's one other option which we have. We can increase the grade by 1 if this cytological atypia is marked. Just to show you an example, on the left side there is glandular neoplasm with some solid areas, which in this case are squamous, so they would not be considered, so that's a purely glandular neoplasm, it's a grade 1. On the right side, you also have some squamous areas, but the rest is also solid, non-squamous, so that's a grade 3. There are only very few glandular structures, plus the geographic necrosis, so all the pink stuff helps you as well, classifying that as a grade 3 carcinoma. So the issue is reported in several publications, for example here, relative large numbers. Even if you combine the grade 1 and 2 in low grade, there's a discordance between biopsy and hysterectomy. In this study, 15%, 9% were upgraded and 5% were downgraded. So why is that? So the first thing is that pathologists do not agree what is solid. On the right side, you see in a solid area in the corner, there's a gland, so that's pretty clear. There's a sheet of patternless nuclei that would probably be considered solid by everybody. On the left side, there is more like a vaguely glandular structure with occasional luminal formation. So some may call this glandular and some not, so-called tight acini. I would belong to the latter group and not call it solid, but there is a high degree of inter-observer variability. And the second issue is there's intratumoral heterogeneity. So this is an example, several pictures taken from the same case. You have grade 1 areas, grade 3, grade 2, and even other histiotypes come into the differential. And this is certainly an issue for endometrial biopsies, where you can't control the sampling. So what are the leaders in the field suggesting? Robert Soslow from Memorial Sloan Kettering says we should move to a binary grading system that certainly would improve the reproducibility. He's saying there's a clear difference in survival versus between grade 3 and the lower grade. The difference in survival between grade 1 and 2 is maybe 5%, maybe reproducibility significant or not. So that's not. But he immediately pedals back and says, well, in our retrospective data, large numbers here, there is a difference of 5% with respect to positive lymph nodes between grade 1 and grade 2. So there may be some information in the preoperative biopsy which could guide the surgery. So what I think to that issue is it can't be fixed. We have to live with what we have. There's some value on grade 2, making a grade 2 diagnosis on a biopsy because it's slightly higher risk of lymph node met. On the hysterectomy, I would recommend to combine grade 1 and grade 2 into low-grade carcinoma because just not reproducibly diagnosable by pathologists. Makes no sense to develop treatment guidelines specific for grade 1 or grade 2. We use this very sparsely in our institution, and in the result we have a bimodal grading distribution with the majority of endometrial carcinoma being grade 1, and the second peak grade 3, and maybe 20% being grade 2. But I see publications from other centers, this is actually a unimodal distribution, so the complete opposite, where the majority is grade 2, with very little in the other one. So it's basically a mess. Issue number 2 is the differential diagnosis between grade 3 endometrioid and serous carcinoma. And there have been, a few years ago, 2 publications basically showing the same, that the reproducibility is not very good. The consensus in histotyping in this high-grade group was about 70%. So it's not bad, but it's not really good. And I just want to put that into perspective, what we know from the ovary. In the ovary, we had the same issue 10 years ago. The reproducibility of cell type or histotype in the high-grade group was poor, and we used immunohistochemical markers as an example for ancillary test to increase the concordance. And that is now a simplified scheme, an algorithm that we use using 4 immunohistochemical markers, WT1 and so on, and this scheme results in 5 endnotes. You probably can't read the endnotes, so I bump up. If WT1 is the first decision you make, if it's present, you go into the one arm, as p53 is abnormal, you have a high-grade serous carcinoma. If p53 is normal, it's a low-grade serous carcinoma. In the other arm, WT1 is negative, NAPS-NA is positive, it's a clear cell. If it's negative, you use PR, distinguish endometrioid versus mucinous carcinoma. So what that shows, for example, is if you have the differential between low-grade and high-grade serous carcinoma, you use p53 because WT1 would be of no use. It's positive in both carcinomas. So this overall has, as a standalone, an agreement with a gold standard histotype diagnosis of 89%, which is not bad. But just want to zoom in into the low-grade, high-grade serous endnotes to show you the numbers. Specifically, the combination of WT1 positive and p53 abnormal correlates with the diagnosis of high-grade in 99%. And that's what pathologists adapt in practice. If they see that combination in the ovary, they basically histotype that as high-grade serous carcinoma. So that's highly specific, but it's not entirely sensitive because there are high-grade serous carcinoma which show normal p53 by IHC and still have the underlying mutation, about 5%. And they can be quite common. You see in the other node, the low-grade serous are only in this node, so it's highly sensitive. It's 100% sensitivity, but not very specific. So you have to look at the details if you want to, use that algorithm in practice. So we tried the same thing now in the endometrium. Our numbers are much lower, so we had more than 1,000 cases for the ovary, and here we started with 100 grade 3 endometrioid and serous carcinomas in the first split. Here is not a cell lineage marker like WT1, but it's p53. If p53 is normal or wild type, it's endometrioid grade 3. If it's abnormal, then the problem begins because a third of grade 3 endometrioid can have p53 mutations. Second split would be p10. If it's abnormal, that's more likely endometrioid grade 3, and so on. So we can also assign the endnotes to certain histotypes. However, in one combination here, we end up with a 50-50 split. So we need more molecular markers, and it's just images from this endnotes. The upper 4 images look more like serous, the lower 4 probably more like endometrioid. Despite having these problems in histotyping of high-grade endometrioid carcinoma, the SHREC consortium led by Alan Altman and Marcus Bernardini and Jessica McAlpine was able actually to show that there's a remarkable survival difference between endometrioid grade 3 in the blue line and serous carcinoma in the red dotted line at 5 years, for example. They also show clinical relevance in the stage 1A group that serous carcinoma recurred at a rate of 19.5%, while endometrioid grade 3 only 8%, so more than double as high recurrence rate. There's probably some biology underlying here, which differentiates those two, and I would think that those differences only can grow bigger if our classification is refined. We followed up with the first biomarker expression in the SHREC consortium, looking at the hormone receptors, and found also differences. The absence of progesterone receptor in grade 3 endometrioid carcinoma was associated overall with a favorable survival. in all stages, but specifically in stage 3 and 4. While for the serous carcinoma, there was a protective effect seen in the low stage, which is quite useful perhaps as a prognostic marker for the serous carcinomas in that setting. So that could be further explored. While PR is not a prognostic marker apparently for grade 3 endometrioid, but the finding that there is a biologic difference in the high stage may suggest that hormonal therapy in the PR-positive grade 3 endometrioid carcinoma could be explored in combination with other therapies. You have probably seen the slide over and over again, but I also want to make a point here from a pathology perspective. Do I have a pointer here? Probably, right? Oh, yeah. So there is a histology column here, and you see that all the serous carcinoma except one case cluster basically in the copy number high, or what I call it, P53 mutated molecular subtype from TCGA. So the serous carcinoma are not really spread out across those POL-E mutated MSI high or mismatch repair deficient cases, copy number low cases. They are really in the P53 mutated group. So basically when I say the TCGA is actually an endometrioid histotype story only. What we did then is we characterized a series of those endometrioid carcinomas by the molecular subtype using surrogates and looked at the reproducibility of or not as all endometrial carcinoma, and looked at the reproducibility of histotyping. And what we found is basically similar to the ovary. In the high grade, the histotyping is horrible, it's like 39%. But in the low-grade setting, it's very good. So pathologists are really able to tease out a grade 1 or grade 2 endometrioid carcinoma with high confidence. But the reproducibility is poor in the P53 mutated high-grade group, and it's kind of not good and moderate in those POL-E and mismatch repair deficient ultra and hypermutated group, which, understandable, have a lot of acquired mutation and show intratumoral heterogeneity. The TCGA already showed that POL-E has an excellent outcome. We followed up on that and showed that is also true for a slightly expanded set of grade 3 endometrioid carcinomas, which is probably clinically more relevant, and I think the story is evolving and more centers showing the same thing. I'm not saying that will stay at the 100% line. There will be almost certainly the occasional grade 3 endometrioid carcinoma, which is associated with an unfavorable course, but I'm certain that it will be above the 95% threshold and will remain as a good prognostic marker, which could be further explored. We're currently in the SHREC consortium asking the question, on the other side, whether there's a difference between P53 mutated and wild-type grade 3 endometrioid carcinomas. In our preliminary data, we're adding further cases, and you're welcome to contact Marcus or me if you want to participate, show that the wild-type grade 3 endometrioid seem to be better, significantly better than the blue line, which is the grade 3 mutated endometrioid. They almost overlap with the serous carcinoma. One word, because I'm talking a lot about P53 immunohistochemistry, and we did some work in the ovary. I just want to explain where the reporting will go in the pathology community is not yet established. What we see is wild-type pattern. That means that we see a variable expression in the tumor, some nuclei strong, some moderate, some negative. So variable intensity, which is comparable to actually the stroma around, where fibroblasts and lymphocytes have also expression, which we now see with more sensitive immunohistochemistry due to much better reagent at the secondary and detection site. And this pattern, we know, has no mutation and will be reported as normal. In contrast to abnormal patterns where we have P53 overexpression, due to the non-synonymous mutation which induces a conformational change of P53, it will not be degraded. P53 will be accumulated in the nucleus. And the complete absence of expression, which is associated, for example, with a stop gain. An early stop gain will truncate the mRNA, which will be subjected to mRNA decay. There won't be any p53 in the tumor cell nuclei. They will all be all blue, but the internal control, the stroma, will express, which gives now a nice difference. And that is a reason, because years ago, the immunohistochemistry was not able to pick up the normal cells, but now we are. And that's why we can now reliably differentiate these two patterns. There's a rare pattern which disrupts the nuclear localization domain. The mutation disrupts the nuclear localization domain and resulting in cytoplasmic p53. How do we know that's true? So we sequenced 170 ovarian high-grade serous carcinoma, found p53 mutation in 99% of those. There were 2 cases we didn't find. 2/3 had the non-synonymous mutation, 1/3 the loss of function mutation like indel stop gain. We had a control group of endometrial carcinoma which were enriched for wild type, and then we overlaid that with our immunohistochemistry. You can look in different directions. If no mutation was detected by sequencing, the wild type staining was always present. So if there's abnormal staining, there was always a mutation. So the immunohistochemistry is 100% specific to predict a mutation. However, it's not entirely sensitive. There were 7 high-grade serous carcinoma which had an underlying mutation which showed normal p53, so has 95% sensitivity. So this is just a summary again, what we see and how we report the p53. We'll put nobody on the spot, so of course, well, this is a normal p53. I showed you the image before. I just want to make the point that if this is reported as positive, because it's obviously some cells show nuclei, then this could be misleading. Oh, I'm locked here. Because positive expression means in that context absence of mutation, so normal pattern. So it means actually negative, right, if you think of that. So that's why we try to avoid the terminology of positive, negative, and switch to normal, abnormal, and describing the pattern. Good. Oh, now I advanced. That's what I think where the journey is going. We still do the diagnosis of endometrial carcinoma mostly based on just an H&E slide. We use immunohistochemistry, but unfortunately in a relative non-systematic way between center and center. In the future, we'll very likely overlay another layer. But from the QA perspective, I think what we want is having several layers of diagnosis that the occurrence that one case falls through all the holes and get misclassified will be reduced. So rather than replacing the one or the other, we should probably work towards an integrated classification of endometrial carcinomas. And these are the thoughts I have. If I have an endometrial serous carcinoma, I make sure that this has a p53 mutation, and I make sure that it should not have any of those endometrioid-like features, because we know HER2 amplification, and there could be value in a clinical trial. With respect to endometrioid carcinoma, I use an algorithm nicely published here in this paper from Jessica McAlpine and Alicia Talhock, which is a simple surrogate of the TCGA classification for endometrioid carcinomas. And if I see an endometrioid grade 3 carcinoma, I ask the question, is this case ultra or hypermutated? I actually expect a very high frequency. We currently in our department have no routine access to pole exonuclear domain mutation sequencing, which would be expected in a subset about 15%. But we do have access to MMR. So I only can speculate about the pole, but I can definitely assess the MMR deficient tumors. And we also can assess the p53. And if p53 abnormal, of course, you always have to go and think, could that be a serous carcinoma by using further markers, as I showed you in the algorithm. And there's a very small group which doesn't belong to either or, which mostly are beta-catenin mutated tumors. Issue number 3, mixed carcinomas. So earlier this year we published a paper on endometrioid or on mixed carcinomas, and these are example images from the publication showing a mixed endometrioid serous carcinoma. So you see the endometrioid show more gland formation with smooth luminal borders, while this is more ragged and irregular and papillary with high nucleotypia on this side of serous carcinomas. WHO says 2 different histotypes, one must be high grade. They changed the threshold, it's now 5% instead of 10%. Doesn't make a real big difference in practice. They suggest that you should use immunohistochemistry to classify these things. And this is a common diagnosis. Just in this large series, almost half of the cases of serous carcinoma were reported as mixed. So it's a common occurrence which you probably face in practice. So in our study, small numbers, I just want to focus on the first line up here. We had 11 endometrioid and serous carcinomas mixed, and we found only in 2 of them, by sequencing and immunohistochemistry, a combination differences between the components, and concluded that these are 2 spatially separated tumors, probably collision tumors. But in the remaining, in 6 tumors, we found homogeneous p53 mutation in both components and no other endometrioid-like features. We concluded that this is an serous carcinoma with an endometrioid morphological area, which is, and in 3 cases we found underlying mismatch repair or pole E mutated in both components, and concluded this is an endometrioid carcinoma, which focally mimics a serous carcinoma. So as immediate knowledge translation and early adapter, after the paper we stopped diagnosing mixed carcinomas in Calgary, at least I do, and try to assess or assign those morphologic serous endometrioid to either a serous carcinoma by using a combination of p53 and mismatch and others, or to endometrioid histotype. Here's an example of what we had after the paper was published. Serous carcinoma morphology here, endometrioid, smooth luminal borders here. I mean, the nuclei are a little bit bumpy. p53 assessed comparative on both. It's abnormal complete absence with internal control, mismatch repair intact. So this case is serous carcinoma. There's another case, serous carcinoma on the left side. Morphology and more smooth luminal borders, endometrioid morphology here, quite different. So that would be morphologically a mixed carcinoma. We used immunohistochemistry. Both components showed underlying mismatch repair deficiency, and the p53 was normal in the endometrioid-looking area, but it was abnormal in the serous-looking area. So should we try it again? The question is, how would you diagnose that case? I was hoping that you would struggle between the answers B and C, which you probably are, and I would have said, yeah, that's exactly what current pathology practice reflects. So we diagnosed. Oh, so I'm somehow locked here. So we diagnosed that case as. We diagnosed that case as endometrioid because it has a homogeneously underlying mismatch repair defect, has a normal endometrioid area, and in a subclone, in this mismatch repair deficient hypermutated tumor, a p53 mutation arose, which now gives rise to serous morphology. So that's what was our thinking. We said it's an endometrioid carcinoma, mismatch repair deficient, with a focal clone of p53 mutation. Now knowing that the p53 mutated grade 3 carcinoma have a worse prognosis, almost like serous, you could argue, yeah, well, this is an aggressive one anyway, so it doesn't really matter. This case was reviewed by Best Doctors in Ontario, and they called us, of course, mixed serous endometrioid carcinoma. I found that funny. Showing an endometrioid clear cell carcinoma mixed, and I just want to point out most of them are endometrioid in genotype and have underlying mismatch repair deficiency as well. Last issue, dedifferentiated carcinoma. The genes, the story here is emerging is around the SWI-SNF complex, which is molecularly a chromatin master regulator. The terminology is very confusing. Protein names and gene names are interchangeably used. It's very difficult. Some of those genes, you know, from ovarian small cell hypercalcemic type are involved in this process as well. For example, SMARCA4. With Cheng Han from Edmonton, my pathology colleague up there, we did a study. We asked our collaborators to send in dedifferentiated carcinoma, but the first thing is we reviewed the cases and found that actually half of them were not what we would call dedifferentiated carcinoma. We would reassign those to grade 3 carcinoma, slightly supported by the difference in Kaplan-Meier curves. So I think there's some sort of overdiagnosis. So this is how dedifferentiated looks like. You have a low-grade endometrial component on one side, and then the same tumor shows an undifferentiated sheet-like component. And the diagnosis to grade 3 is difficult because where is the border of solid to discohesive growth? So morphologically, that's very challenging. We sequenced, again, both components separately and found that those genes involved in the SWI-SNF pathway were mutated exclusively in the dedifferentiated component, suggesting that they are involved in the progression of that disease. And luckily, there were antibodies showing that those truncating mutations were actually in the component, so we could follow up with immunohistochemistry, so this SMARCA4 and SMARCB1. And this table nicely summarized now that we have diagnostic markers for dedifferentiated carcinoma because we found mutually exclusive mutations or loss of expression of SMARCA4, SMARCB1, and ARID1B in 80% of dedifferentiated carcinomas. So we now explain 80% of dedifferentiated carcinomas in the endometrium, and so far this is highly specific to versus grade 3 and makes sense. Interestingly, this seems to develop in a mismatch repair deficient background more commonly. It seems to be a risk factor, but it's not exclusively. So this is slightly enriched, but not useful as a diagnostic marker between the two. P50 mutation can occur in dedifferentiated, but are much rarer than a grade 3. And thinking of the biology, it makes sense that our usual cell lineage marker like PAX8 and ER are not expressed in dedifferentiated carcinoma because this is basically inducing a differentiation block. These cells remain undifferentiated by morphology and, of course, don't express those markers. And so these can also be used with certain limitations. So I don't want to go into this question, or the answer here was grade 1 is the most stable error currently. Well, I think those will be fixed in the upcoming years. I think there's a lot of heterogeneity across pathology departments, how they use it. We have this, again, as early adapters right away transferred into practice and now stain all our dedifferentiated carcinoma for that. So we think we're making very specific diagnosis here. But other centers may not have even heard of that. So in summary, I think there will be changes towards an integrated diagnosis. The TCGA story will be one of the endometrioid, and mixed carcinoma are exceedingly rare. And now we have diagnostic markers for the dedifferentiated carcinoma. And just want to acknowledge a short slide, which I also prepared last minute, so it's not very long, but the most important people here, Cheng Han, pathology colleague from Edmonton, Greg, our local gynecologist in Calgary, and of course the Shrek key people. I just want to mention that all the work I did was only funded by Calgary Laboratory Services. Because when I put in a grant application, I always get the comment, that's not important. That is not important. Thank you.